Good afternoon, everybody. Post-lunch session. So I'll be talking about progressive myopia, which is a little offbeat of the what the instruction course is about. So as we all know, myopia has been increasing prevalence in the last 2 years, especially post-COVID. We have all seen in our clinical practice. And it is estimated that in 2020, there were only 2,620 million cases of myopia, which is going to increase to 3,361 million by 2030. But more importantly, the high myopia, which leads to pathological myopia and macular degeneration, this is supposed to become the most important cause for irreversible blindness worldwide. So that is the reason why we are so much worried about this progressive myopia. Previously, we used to think myopia is only genetic, and we used to ignore all the other factors. But now we have enough evidence to say that besides the genetic factors, environmental influences have a very great role in onset and progression of myopia. So now we know that it's a complex interplay between the environmental and the genetic factors, wherein the control mechanisms are no longer able to coordinate with the growth and development of the optical components of the eye. And there is also this peripheral defocus theory. So what exactly is this peripheral defocus? Like suppose in uncorrected myopia, when the light falls through the center of the receiving eye, it falls in front of the fovea, as we all know. Whereas in the peripheral area, since the eye is actually not a perfect sphere, it's oval in shape, the peripheral rays are overshooting either on the retina or behind the retina. So this is something called the hyperopic defocus. So when we are giving a normal correction, like in a normal spectacle thing for myopia, we are going to correct only the central rays. So the central rays focus on the retina, whereas the peripheral rays gets more defocus, means gets more hyperopic. It focuses behind the retina. And this peripheral defocus has been a very important factor in the progression of myopia, because this leads to some cellular and biochemical changes in the retina and the RPE, leading to changes in the scleral extracellular matrix synthesis, which alters the biomechanical properties of the sclera and in turn leads to increased ocular growth and myopic shift. So why at all we are worried about this progressive myopia? Why should we just bother too much about it? Most important, as I said, this degenerative retinal disease, because this has been hypothesized to be the cause for the most important cause for blindness worldwide in the coming years. So currently available modalities for this progressive myopia, the one is the regular spectacle lenses, the contact lenses, but now the importance is on the environmental factors as well as the pharmacological modifications. So environmental effect has been shown clearly to have a very huge impact on the onset progression of myopia, and hence modification of these factors or reduction of the exposure of the eye to these influences may definitely slow down the progression. So it has been recommended that at least 2 hours of outdoor activities for children has been shown to significantly reduce the rate of progression. And the mechanism is that the light stimulated release of dopamine from the retina, and then this dopamine is supposed to inhibit the axial length elongation. So here it is important to remember, it's just not the physical activities, it's just being outside in the exposing to the sunlight, that itself has been shown to reduce the rate of progression. The optical coming to the next factor is the optical factor. Optical undercorrection has been the very age-old method of treating, but however current evidence is against this undercorrection of myopia, and in fact it may lead to more progression than normal. The bifocal and progressive lenses have also been used in effort to reduce the accommodative effort, and this particularly is effective in children who have the accommodative lag. They usually have a esophoria on near fixation. So such children, the progression of myopia can be halted to some extent by using this progressive glasses. Of late, there has been a lot of interest in this DIMS lens, the defocused incorporated multiple segment lens. So this is based on the peripheral defocus theory, which I just discussed. So here you'll have a central area which gives the clear optical correction for the child to see, and the peripheral area is hyperopic, means it has about plus 3.5 hyperopic segment. So thereby the hyperopic defocus, which is supposed to be happening in the peripheral retina, is avoided, and this has been shown to reduce the rate of progression of myopia in many children. and it has been extensively used nowadays. We also have contact lenses in a similar the same platform. So in this is one of the most popular daily disposable lens available. So here again there are treatment zones and the zones for the optical correction, so that the central area, the vision is still clear for the child, but at the same time we are avoiding the peripheral hyperopic defocus, and we are creating into a myopic defocus instead of a hyperopic defocus. So this has been shown to again reduce the rate of progression. Ortho keratology has been a very age-old method when you practiced especially from by optometrists, and of late a lot of ophthalmologists are also using this one. So the basic principle is the child is made to wear a hard contact lens and sleep. So because the eyelid pressure is on the lens is supposed to flatten the cornea, and when the lens is removed in the daytime, the myopia gets corrected. However, I have no much experience about this ortho K lenses. The pharmacological modification has been the most important innovation in the last few years, and atropine is the only medication which has demonstrated to be consistently effective. I'll just discuss about this ATOM study. So how does atropine work? Atropine works not through the accommodative system, but it affects through the M4 and M1 and M4 receptors, and on the non-muscarinic and a direct influence on the scleral fibroblasts. So this was a very big study done in Singapore National Eye Center, the ATOM1 and ATOM2 study. So the ATOM1 study used 1% atropine, and however this was affected with a lot of problems because of the pupillary dilation, photophobia, and difficulty in near vision. And not only that, the rebound myopia was higher on stopping the treatment. Whereas the ATOM2 study used the 0.5, 0.1 and 0.01 atropine for treatment. And in this study, they found the 0.01 works the best. So the 0.01% works the best. It has a significantly lower progression compared to all the other concentration, and also the children tolerate it very well. So atropine causes very minimal side effects, especially the 0.01%. This thing does not have much of blurring of near vision or photophobia, unlike the higher concentrations. So combination of therapy, combination of intervention is probably the way to go. So we have to see the child, the family history and all the other things, and then decide whether a combination of atropine with the multifocal spectacles or orthokeratology with low dose atropine, whichever works for the child the best. So a word about the pre-myopes. This is very important because we have to focus our attention on these children. So presence of 0.75 diopter or less of hypermetropia at the age of 6 years indicates that this child is more likely to develop myopia. So hence we have to give a lot of importance to these children, and especially if there is a family history of myopia, parents or siblings having myopia. So such children, we should encourage them to spend more outdoor time and try to restrict the myopia. So in conclusion, outdoor time is the most promising intervention method for preventing progression of myopia, and consistent evidence is there for use of 0.01% atropine eye drops. And of course, information is constantly evolving, and we have to stay abreast with the latest studies. Thank you.
Thank you, Dr. Arun. And if anyone has any question about this use of atropine for myopia.
Madam, your comments. Kuldeep sir. What's going to happen?
Okay.
Thank you,
Thank
sir.
you. Thank you so much. And now we'll move to the pediatric cataract session. And the first talk will be by Dr. Suma Ganesh, as she has to leave for another hall. And she would be speaking on pediatric cataract surgery in infants.
Good afternoon, and thank you, Dr. Love, for giving me this opportunity. Pediatric cataract surgery in infants, my topic is. So we need to operate them as early as 6 weeks if it is unilateral, and if it is bilateral before 8 weeks of age. Very few children actually present at this age, but now with the with the awareness programs, we are picking up children as early as 8 weeks. So if early surgery, the biggest problem is anesthesia related complications, because it may be easier to do the surgery, but I think the most difficult task what I find is anesthetist and anesthesia. So the other is because the eye is microphthalmic with varying degrees of developmental arrest in the cornea, iris, drainage, angle and retina. So we have to be careful, and that means complication rates of aphakic or glaucoma is very high. So even if there is a PHPV also, we need to look up, especially when you're seeing the ये आप कर रहे हैं अच्छा वही कोई और, मैं सोचा मेरा हाथ जा रहा है. Okay, so the PHPV is presented up to around 25% of all congenital lens opacities. ये आगे नहीं जा रहा है. So the challenges are basically what I find is that the main challenges are whether to put an IOL or not to put an IOL. Axial length increases rapidly in the first 6 months, and we know that up to 1 year the axial length is increasing rapidly. Steeper cornea with high keratometry values. So whether to put an IOL before 6 months of age or after 6 months and 1 year, I'm convinced that we could put an IOL. Less than 6 months, I'm still not convinced. I am still controversial whether I should put an IOL or not put an IOL. So now sometimes I feel in bilateral cases, should I wait till 6 months and then put an IOL? So because the target refraction, what I find is that whatever you calculate, I have reduced 10 diopters in a less than 2 months, 3 months. I have reduced 9 diopters in 2 to 3 months. 4 to 5 years I reduce 8. But I still find the prediction error is not predictable at all. Every time after there are surprises, and that is what is scary. So less than 6 months I put an IOL, but I'm not sure what my prediction error is going to be. So I would advise you can undercorrect as much as 8 diopters when the child is around less than 6 months of age, if you're putting an IOL. And so infantile aphakic study was done by Dr. Wilson and Lambert, and they found that they had a lot of problems. In our studies, we have done, we studied the prediction error we put the IOLs in children less than 1 year. It was 66 eyes. I said, let me do a study myself and see my evidence based. The IOL power range from 15 to 40. I have even put a 40 diopters in some, and in that case, in those 2 cases, I found the maximum prediction error. They are now 3 to 4 years of age, and they have a minus 15 refractive error. Prediction error. So I am always wondering whether I should have put, and those babies were 2 months of age, and I had put a 40 diopter IOL. Still the prediction error in those babies were around 15. So those 2 cases I'm following up very closely. I may have to explant or do an IOL exchange. So less than 6 months and very high. So what I found was that do not put an IOL if in less than 6 months. If you are putting an IOL, do not put it if your axial length is less than 18 millimeter, because lot of prediction errors. If you have an axial length more than 18 millimeter, please go ahead and put an IOL. But less than 18 millimeter, all the 3 cases which I got surprises were less than 18 millimeter. So don't put them. And that's the only factor which affected the prediction error. Myopic shift also was seen much more in patients who I operated less than 6 months with an IOL. The mean logMAR visual acuity of both of the cases were very good. Of the bilateral cases was 0.482, which is very good, and even the logMAR visual acuity was 1.033 in the eyes with unilateral cases. PCO rate was comparatively less, of course, because we have good vitrectomy machines, and though infant aphakia study said that their main rate of reoperation around 74 to 82% was because of the membrane formation. But I think because we do more cases, I'm not sure, or our rate was not so very high, but we still need to do a bigger axis, and no glaucoma was seen in children when, at least in the pseudophakic variety. I did not find glaucoma in most. I'm talking of only 66 eyes. It's not, but now recently also I may have added on around maybe 100. There's been no case of glaucoma, but aphakia, yes, I've had cases of glaucoma. So that could be one advantage. I think there are better videos than me by Dr. Arup. So I would not. I'm just showing you few. Dr. Arup has wonderful videos. I've seen his videos, and then I feel like, okay, I'm my videos are not very of that quality. But I just want to say that anterior capsular access, I still do it with the Utrata forceps, though I've seen all the other surgeons do. I'm quite comfortable with my Utrata forceps. I've been using it from the last 25 years. Of course, the microrhexis forceps used by others is equally very good. And the biggest advantage is that you don't have to make an incision in the main port, and you can still do the rhexis. Now, the biggest nice challenge in pediatric cataract, what I find, is the variety of, you get different types of PCC, posterior capsule, you get different varieties of anterior capsule. So, because of its rigidity as presented in the previous talk by Dr. Coker and the rest of the team, I think the rhexis is something which we need to keep on practicing. So how I learned was that I first did it in children, say 2 years more. If you go from backwards as learning curve, say 8 years to 6 years, I do the cataract, and then I go back, and I find that the capsule is much different when you go to younger children. So it is. So this is with the microrhexis forceps. I do only few cases with the microrhexis forceps. I'm still comfortable with the Utrata. So this is the microrhexis forceps where you need to I use Helon in children because I find that using visco, it's not a question of money. You will not get the same result as with visco because you are keeping on injecting and the visco keeps coming out. So it's better to do with Helon because for the child it's once. You cannot make mistakes in this. So the posterior capsule, I'm not going to. So if you have the posterior capsule also, it is important that now this posterior capsule access, I make a nick and raise the flap, and I do it manually because I am quite comfortable manually. I only do it with the cutter when I find that it is very, very flimsy. Like in some pediatric cataracts as small as you find that the capsule is very, very flimsy, and so it does not get stretched on it, does not get pulled. So moment you feel it cannot get pulled, it's better to go with the cutter. But the disadvantage with the cutter is that I find that it is not smooth, the edges, and when you are putting the IOL, then there's a tendency for it to extend. So I find that the manual is much better. Even if I've had a case where my IOL had dropped, I put the IOL, had gone into the bag, and it was hanging like this inside the. I pulled the lens out. My PCC remained intact. So that is a best of the manual PCC. So this is with the cutter. If we have cases like this with thick posterior capsules, in this you have to use the cutter. The problem with the cutters now I am facing is that now most of the companies have stopped the 20 gauge cutter. I don't know if all of you know that they have stopped 20 gauge. Now they give us only 23 gauge and 25 gauge. Like we have Centurion Constellation, which gives us only 25 gauge now. These plaques don't get cut with 25 gauge. So you need to use then you need to use a retinal forceps, scissors. 23 gauge still cuts this, but I still find even with 23 gauge, you are not able to cut all these thick thick plaques. So, but the companies have just stopped making. Like I'm going to come and I decided to go and ask why they stopped making 20 gauge cutters. So because these are few cases where you need the cutters. So one thing which I would say is that microcornea less than 9 millimeter, I will not put an IOL in a small baby. Ethically, it's not right to put an IOL because I find that they develop more and more complications. And if I see on my axial length, if I measure and I see less than 18 millimeter, I still will not put an IOL. Otherwise, I'll go ahead and so I still do it with the Utrata forceps. So with the Helon, this is a 11-month baby, and so we this of course this rhexis will come with you keep putting Helon because it's a smaller baby. What we find that it keeps getting so the rest of the procedure, what I find is that if you can do phaco as adult cataract surgeons, pediatric cataract is not very difficult because most of the steps, I think, from have we grown over the last 30 years, because we we have I find that we see now the procedures much simple because that time we didn't have phaco, so we were not using these techniques. But I think the tunnel, the rhexis, the bimanuals, all this have revolutionized pediatric cataract surgery, and you hardly find. Now in this case I had to use the cutter, so I use the cutter. Now the cutter for the flap is different than the cutter for the vitrectomy. So you use, like suppose now I use the turbo because we have turbo and Constellation. So in that then we have to increase the you have to make the cut rate less for the when you are putting for the flap. and you can increase the cut rate to around 1000 for the vitrectomy. So if you fear that you do not want the IOL to go down, so you can, sorry, I've decided to suture. You can put it first in the iris, and then you can rotate it into the bag. And Acrosofts, I'm not, there's no financial here, but I still use Acrosoft single piece lenses, and they're very easy to put into the bag. So we don't have to struggle with your PCC. The important thing, of course, is the follow-up. I'm not going to go more into detail. I think my time is up. But what I would say is that do not fear a phakia, because I have now, this baby is grown big. He's just now, all of these are babies who have operated. They are studying in college. I put a secondary IOL after a phakia. They're doing PLI4. This is just 2 or 3 cases I'm presenting. But don't think that we have to put an IOL, and don't mess up the eye. Like this boy, he has a corneal diameter less than 10. I have not put an IOL, microcornea. His father was a pharma industry. He told me, please put it. I said, I have not put an IOL because his corneal diameter. Today he's in 12th standard. He got an award, and he's 6'9", and his glasses prescription only +4, +5. And he's a phakic, and just on anti-glaucoma drops. But I think we should not be overdoing when we put an IOL. And I think that's all the message I wanted to convey. Thank you.
Thank you, ma'am. And do we have any question? Just one query I had. +40, which company did you get?
No, +40 you get from SP. Microsoft single piece. MP has only up to 30.
You will get from AIOC.
Oh.
AIOC are able to make up to +60.
Okay, but
Yeah, but that is a hydrophilic material, but that is it's a bit bulky. It is bit bulky, like Renner design.
Microsoft SP single piece.
60.
Yeah.
Up to 40. Yes.
MP you don't get. Multi-piece up to 30.
Multi-piece is 34.
34 you're getting multi-piece we're giving in Delhi only up to 30.
yeah, up to
Sorry, 30.
Single piece 40 for a small, for a
Oh, it's very thick. Very
infant
thick.
is very, very
Very
thick.
thick. No, it's difficult. I'm not saying.
what I do, I generally don't implant more than 30.
Johnson and Johnson is up to 34.
It's a 3-piece is
So
not
see,
a
these are when we are younger, and these are all my old cases. Now I wouldn't put it. So I'm just saying, when we are younger, we want to put IOL in all children. But they are now, the child is having that 40 which I put, in spite of that, which is having a myopic shift of -15. So I'm regretting putting it. So
But the thing is, what we
So what would you advise? You will remove the IOL, or you put an iris claw on top of it? If it's a -15.
No, it's a small eye, no?
To remove
Even explantation, a whole bag will come out.
the whole bag. So I was thinking just to put an piggyback, like,
But that is also, I think,
Small eye.
3 months when you, I have.
No, now the child is big. Now the child is 6
What I
years.
have seen is the
But even then, eyeball size is not.
more than the axial length, I have seen the K value reducing drastically.
Drastically, yeah. Steep corner.
Within few months, they become.
Yeah.
It is +15 probably at the time of surgery. It reduces to +6 in 6 weeks. Sometimes, if you have implanted.
Poor prediction in early age is more due to K changes rather than axial length.
I'm so sorry. Sorry.
Thank you so much, ma'am. And we were supposed to start with this talk, but since she had to leave, then I took it as the second one. So just to start the session, we will go through how pediatric cataracts are different. And this is a video which I always show in most of my pediatric cataract presentations. This was a surgery done by an adult cataract surgeon, and that is what the mistake we do when we start doing pediatric cataract without much of training. This was a single piece IOL, and half of the iris is missing. Lens has been placed in the sulcus with some corneal touch. So, and the worst part is that this child will have to stay with poor vision for the rest of his life because of poor work by the surgeon. So that is why it is very, very important that we do these cases with utmost care. And in this case, what I did, I explanted the IOL and I left the child aphakic for the cornea to settle down. Initial, the lens is cut. But eventually didn't do well. and visual outcome was not good in this child. So next comes the IOL power calculation. Definitely it is not a miniature adult eye. Pediatric eyes have a shorter axial length, steeper cornea and smaller AC depth. So error in axial length measurement affect IOL power calculation, and second part what we discussed was the rapid change in the keratometry values. There is an increase of 3.75 diopter per millimeter in children when compared to 2.5 diopter per millimeter in adults, and a scan reading with maximum anterior chamber depth should be taken. Requirements: this is the basic requirement for anyone doing pediatric cataract surgery. Nowadays, that based on axial length, the IOL formulas have become obsolete, so a handheld keratometer is a must. And what we do is that though a touch procedure should not be done before surgery, but just because the child is to be taken twice under general anesthesia, we do it with utmost precautions, and the K reading is taken, then the axial length is measured, and we keep a full series of the intraocular lens handy, so that in the same sitting the surgery can be done. And it is very important to avoid speculum, because once the speculum is tight, that may affect the keratometry and axial length readings, and proper corneal hydration has to be done. Target refraction: in adults we target for emetropia, but not in children. Children we target for hyperopia depending on the age. If it is a unilateral cataract, then the status of the fellow eye. Compliance issues are also there, and one of the reasons for early IOL implantation in children is poor compliance with children of rural background with contact lens, and that is again more for unilateral cataract. For bilateral we can always give aphakic glasses. Timing of surgery: bilateral in adults, definitely it is an elective procedure, but in children, if it is a bilateral cataract, it should be operated before 8 weeks, and earlier if it is a unilateral cataract. In unilateral cataract, generally myopic shift is more in the affected eye, so the other eye refractive status has to be taken. And in bilateral cataract, second eye generally we operate within the first 2 weeks of the first eye. In visually non-significant opacities like blue dot cataract and posterior polar cataract of less than 3 mm can be kept under close follow-up. And another difference is that in adults we always implant a IOL, but in children, if it is a very young child with a shorter axial length, corneal diameter less than 9 mm, I am one of the surgeons who generally I don't do before 1 year of age, and again that is preference surgeon to surgeon, but definitely there is a consensus that below 6 months better to avoid IOL. And to be on the safer side for beginners, you can keep it up to 1.5 to 2 years. And what the lensectomy is done, generally we leave an anterior capsular rim. Another important issue here is the thickness of the rim. If it is too thin, till now in my case series of last almost 20 years, 2 lenses have dropped into the vitreous cavity due to very thin rim. Just last week I saw a case which I had operated in 2017, and now the child has come with lens in vitreous cavity. And in unilateral cases, contact lens is a better choice if you are leaving the child aphakic. What IOL? In adults you have a full range of IOL selection, but in pediatric definitely hydrophilic lens is not a choice. Hydrophobic or PMMA, more importantly it should be hydrophobic. Aspheric blue blocker again is a controversial topic, but many senior surgeons have been using it. Toric at a later age when the child's refractive status has stabilized, and if you are operating a cataract, or if there is a very high cylinder in a younger child, that also, in those cases also toric is a choice. Multifocal I would not suggest, and single piece and 3 piece is again I would say it's surgeon's choice, but if it is in the sulcus, definitely a 3-piece lens. Capsular Axis, this is the most important difference between a pediatric and a adult cataract case, and anterior capsular axis has to be done with forceps. Many people, even in adult cataract, they prefer forceps, but in pediatric, cystitome is generally avoided. And posterior axis, either you can do it manually or a vitrector axis. We have we have switched to exclusively to vitrector axis because it takes much less time and 100% of the IOL is in the bag. So why to go for a procedure which has a longer learning curve and it takes much more time, and if you lose the posterior capsular axis, then unnecessarily you will have to place the IOL in the sulcus. This was one of our publication in which we compared vitrector axis with forceps capsular axis, and what we saw, the two major differences was first was surgical time. In the period in which I did the posterior capsular axis case took almost 20-25 minutes, and this took 10 to 12 minutes. And anterior vitrectomy is done in all cases, and we are more on older children now. I've been doing it for almost 12 or 13 years also. So the posterior capsular axis and anterior vitrectomy. And another difference is that in younger children, the main port has to be sutured, and definitely up to 7 years of age. Beyond that, we can decide it on case-to-case basis. And in infants, occasionally even the side port have to be sutured. The main important thing is that the anterior chamber has to be stable, because if the anterior chamber becomes unstable and the iris gets plugged into the side port, the post-op outcome and generally it becomes quite poor in these children. And the most important part is, in adults a good surgery is the end, in children a good surgery is just the beginning, because after that you have to have a frequent follow-up. The amblyopia has to be treated, visual axis opacification has to be looked for, and IOP monitoring has to be done, especially when children have been operated at a much earlier age. And follow-up may be initially every 2 to 3 months, and later on, once the patching has been tapered, it can be 6 monthly. Thank you so much. So if there are any questions, we'll be happy to take. Yes. Two choices are there. Either use 10-on nylon or a Vicryl. If you are using a Vicryl, there is no need to remove. If you are using 10-on nylon, now what I've been doing, because with time it becomes loose and then then mucus settles there. So at 1 month, I generally remove the nylon sutures. But if you are using Vicryl, you need not remove it.
Because I have encountered two cases like where I put 10-0 nylon sutures, and they have come out with endophthalmitis.
Yes. That is why at 1 month I have been doing it for every child.
I have shifted to 10-0 Vicryl nowadays, so I think. And the GA issue is also, and again you have to put the patient as.
Yes. Don't wait for it to loosen up, just remove it at 1 month.
What time duration should you keep, like after one month time?
1 month.
You can,
But endophthalmitis is very rare. There's a corneal infiltration.
Yes.
Actually, patient neglected this issue.
The main concern was that in one case I operated for the other eye on the same day, and the other eye removed the sutures after 1 month. So that was the main concern for the other eye actually. So.
What I do if I'm doing nylon, I operate both eyes, and then 1 month after the second eye, I remove sutures of both eyes together.
Okay.
And that's just the mask. So next we will have Dr. Arup Bhaumik, and he will be speaking on anterior and posterior capsular axis in pediatric cataract.
So in the meantime, you can take question. You can discuss any important issue regarding biometry lab.
Regarding biometry, one thing I missed was what formula do you use? Madam, can you tell about the formula what you are using? Yeah. Hoffer Q you can use, but again in children, if it is a smaller axial length, we avoid.
What happened?
Longer eyes, shorter eyes, do you compare?
Shorter eye Hoffer Q,
Hoffer
otherwise
Q.
a circuit T works quite well.
And something about capsular phimosis. I recently had one kid, his IOL was same, about 40. Single piece I had put. That time everything was fine. But I think after about 7 to 8 months, I saw that it was capsular phimosis was happening. Then I had to take him up and... yeah, just 1.5 years.
Maybe initial capsular axis was on the smaller side.
Smaller
That could
side,
be.
but that
There
was not
may be
very-
some zonular abnormality. Otherwise, generally
Ah,
capsular.
yes, yes.
phimosis,
It became very small. It became very
But
small.
I generally don't implant beyond 30. Rest I give as a spectacle correction. Yeah, yeah. Yes, yes.
But so that's why I wanted
Very
to
thick.
ask
In a
whether there
small
was
eye,
any
itself
problem
will be very
implanting a very high-powered IOL in a small kid, because single piece. Yeah, I ordered and I got single piece, so I thought I can easily implant it, because single piece is something which we put it. I don't know. That was the reason, because I have done smaller kids, but I've never had this capsular phimosis, and it was only anterior capsule which phimosed. And finally, I had to go in and enlarge it, and I was able to enlarge it and make it big. It was I don't know, ma'am. It was a slit lamp was not possible, but it was not a typical zonular cataract. It was like zonula with multiple spots in between. Child didn't have any other systemic complaints.
Good afternoon. Thank you, Dr. Lob, for inviting me and AIOS for giving me the opportunity. My topic is anterior and posterior capsular rhexis technique in pediatric cataract. But I'll focus my lecture today mainly in posterior capsular rhexis. But actually, there is a lot of session regarding anterior capsular rhexis in adult cataract. Almost anterior capsular rhexis is almost similar to all the cases, even in pediatric cataracts, except there is a increased intraocular pressure, lenticular pressure in cases of pediatric cataract, and these capsules are very elastic, and chances of runaway is very high, and tendency to be a larger rhexis. If you don't concentrate on the size, it always become a larger size, and because in that case you has to have use the good OVD like Hilon GB. Even I don't mind to use a viscode, because dispersive viscoelastic is very good. If you tamponade with the viscoelastic viscode and use Utrata forceps or the microrhexis forceps on the side port, you will give you'll able to achieve a good capsular rhexis. But generally it is always better to start a smaller one. When those surgeons who do regularly adult cataract, the larger number of adult cataract in their surgery, they generally make the larger size of capsular rhexis in case of pediatric cataract, because they have a feeling which is that feeling in the pediatric cataract should be different, because that's a elastic, it gets tend to be larger than the adult cataract. So it is better to start it small. So the idea of the posterior capsular rhexis is main idea of the cataract surgery is IOL should be implanted in the capsular bag whenever, however it is possible in pediatric cataract. Better to avoid in sulcus fixation IOL, and it should be visual axis should be very clear, so that we have to keep concentrate on the posterior capsular rhexis and anterior vitrectomy. So how we approach the approach to clear the visual axis. We can do the posterior capsular axis followed by anterior vitrectomy and then implant the IOL, or either that Love already discussed, you do implant the IOL and do the anterior vitrectomy and posterior capsular in one go. And the most of the surgeon is now doing this technique, because now with availability of good type of good vitrectomy, and with in every phaco machine, it is very easy to do control your vitrectomy and capsulotomy with the good vitrectomy machine. It either it is a limbal, most of the cases, very rarely you need to approach through the plasma, and it's very special situation. And one thing, some surgeons still don't practicing in different center, especially some, I know this few surgeon, they regularly, they have a daycare clinic, they operated in their own setup for the adult cataract. For pediatric cataract, as GA is needed, general anesthesia needed, they do the surgery in the another nursing home where the GA setup is there. So maybe there is not portable, they carry their portable phaco machine, vitrectomy machine there. Then it is sometimes very difficult to get a very good vitrectomy there. Then it is very easy. I advise them to do this. Do a posterior capsular axis, then implant the IOL, then do the vitrectomy, so that it can control your vitrectomy part, and it is much easier than the first choice that do the one go first anterior vitrectomy and posterior capsular axis followed by the IOL implantation. I am just showing my video. This is a case, the conventional one, and they make a nick with the needle, and always prefer to put a viscoelastic, especially preferably Hilonjibi, whether any kind of, to push under the that nick of the posterior capsule, so that it can uplift the posterior capsule little bit, and it reduce the traction of the posterior zonular fiber in the posterior capsule, and then it is very easy to perform the posterior capsular axis. It actually, to put the viscoelastic through that nick and lift the posterior capsule, it allowed the reduce the traction of the posterior zonular fiber over the in the posterior capsule, and you can do the then vitrectomy. And how much do a vitrectomy? It is advised in the literature, you can remove up to 1/3 of the anterior vitreous, there will be no problem. Whether it should be your vitrectomy should be sufficient, otherwise if you do the less amount of vitrectomy, and sometimes it is very difficult to put implant IOL into the bag. So my preferred lens, definitely this Acrisoft single piece. I don't have any financial interest. Probably most of the surgeon prefer this lens in pediatric cataract. And this is a technique most of the surgeon using following this, make a implant the IOL and do the anterior vitrectomy and posterior capsule in one go. The technique of this, they make a make a nick with the vitrectomy first and do the vitrectomy first, not enlarge the posterior capsular axis first. Make a vitrectomy first, it will reduce the vitreous pressure, then you reduce your vacuum. It's keep only 100 or 120, even you keep it in the very low, and with the highest cut rate you gradually increase your capsulotomy. So the step 1, make a nick. Step 2, do the vitrectomy, sufficient vitrectomy, then with the reduced vacuum pressure you increase the posterior capsulotomy at your desirable size. That in that case it is very controlled, and you can make a very round with low vacuum, you can very round and good rhexis with the vitrectomy. And as I said, this is a technique, and where your vitrectomy machine is not very good, you can do the postcapsular axis first, and don't try to attempt that time the vitrectomy. So I always before starting the postcapsulotomy, I always put viscoelastic in between space in between the anterior vitreous space and the postcapsule to lift the postcapsule. Now put the sufficient amount of viscoelastic to create the fornix and implant the IOL first, and then after implantation in IOL into the back, then I start vitrectomy. And in that case, the hydration of the vitreous will be little. So it is better to you can complete the case without much of vitrectomy. This is advisable where your vitrectomy machine is not so good. So otherwise, if your vitrectomy machine is good, it is better to implant IOL and do postcapsulotomy and vitrectomy in one go. I'm not showing this case, and this is not a to be frankly today I am just allowed to do only the traumatic cases and these type of pediatric cases in my institution, because juniors surgeons are taking care of all the all kind of developmental cataract or cataract. I am given only these type cases. I deal only the traumatic pediatric cases nowadays. This is a huge fibrosis, make a nick with the MVR blade and complete the complete, because in these cases it is not possible to go through the limbus, because that there is a fragile capsule in the area of coloboma. If you try to tilt the lens, there will increase stretch in the every time it can go away rexis. So it is better to go through the plat spina in cases of rexis. So, and as I am doing this type of case now, I am given I am just not given the all routine cases. This is a traumatic cataract, and pediatric cataract, traumatic cataract, every case is different. Every case is different. Every case is challenging. So this is a case referred to me, and this is a just 7 years old boy and slightly older trauma, and treated with conservatively steroid and antibiotic. I saw there is a rupture, and after cleaning of the cortex, I have seen that there is a huge jonular dialysis. I already removed the bits of anticapsule. So what to do now? This is a very important that postcapsular axis in the chidil, when it is get fibrous, it very easy to handle. So I make a postcapsular axis bearing this jonular dialysis area, and able to make a good rexis, because it is not very difficult to make a rexis when the postcapsule is little bit fibrous. So then I do the vitrectomy first, and this extensive vitrectomy, so that I reduce the lot of vitreous, so that I can and put the lens in the sulcus and capture the optic with the postcapsular rexis. So these type of cases in traumatic pediatric cataract, every cases is very different. So you have to deal the corneal problem and also the cataractors problem. That this is the case, the slightly older children. The patient, the whole bag is subluxated. Here is a huge jonular dialysis, and the lens and the PMMA lens into the in the sulcus, and the lens, the optic of the lens into the anterior chamber. So I have to remove this. I remove the IOL, make a SICS wound, add this a rigid lens. Then I make a vitrectomy, vitrectomy cutter, And as nowadays we are we had a good vitrectomy with a very high kite rate and very minimum vacuum. We can control the postocapsular axis, and there is a huge zonular dialysis, and I make a make a postocapsular axis with the larger size 4.5 millimeter into the postcapsule, and taking care of the vitrectomy, because I will remove the lot of antivitreous here and put lens into the sulcus and capture the optic. So I follow up this case even with the zonular dialysis. I follow up this case almost 2 years, and the lens is absolutely in the center, and patient having a good vision, 612, around 612 vision. So thank you so much at all with this, because I deal only nowadays, I only deal the traumatic cataract.
Thank you, sir. And do we have any questions regarding capsular axis? One important thing, I think it has been covered in parts. There are two types. One is fibrosed and one is normal posterior capsular axis. So the vitrectomy settings, as you could see here, it was a very, in a normal posterior capsular axis, it was a very high cut rate, almost 2500, and then you get a very round, with a 23 gauge, you get a round capsular axis, and if it is a fibrose, a lower cut rate and higher vacuum. Yeah.
Your cut rate should be less, but vacuum should be slightly higher side.
Another small tip, if you stain the anterior capsule, make sure you don't put too much stain, because if PC gets stained, your access is difficult. And while operating, if it's the glow is not good, you can adjust your retro illumination. You can switch off the main light and only use retro illumination, which really helps with your posterior axis.
Thank you. And next we have Dr. Kavita, and she would be speaking on, this is again a major section of pediatric cataract, which is traumatic pediatric cataract.
Very good afternoon, and thank you, Dr. Love, for this opportunity. So, pediatric cataract itself is very challenging, and on top of that, managing trauma in the setting of children's eyes is double challenging, right, as we all know. And pediatric traumatic cataract, I'm going to just brush through some challenges we face and tips that we can follow. So trauma, like first, it is step by step we have to manage. So first is to restore the integrity of the globe, if it's a globe trauma. Second is to restore visual axis, clear the visual axis, and then optical correction and amblyopia treatment. This is the order with which we should follow. So as we know, trauma can be blunt or penetrating, and all sorts of presentations can be there, depending on where it can be present to you at emergency as soon as the injury occurs. It can present at various times after the injury in various aspects. And blunt trauma, the common features are intact cornea, if not too severe. Total cataract is common. Iris issues can be associated, like sphincter tears and dialysis, etc. Lens stability is always a query, and posterior capsular status you have to be wary of, even if anterior capsule is intact. And angle anomalies, angle injuries can also be coexistent. And of course, posterior segment issues should be looked into by other modalities like ultrasound. And after the surgery, if the visual axis is cleared, then you have to take a look into the fundus to see if concurrent posterior issues. Penetrating trauma typically causes more of corneal trauma. Capsular integrity, again more of anterior capsule involvement, and if severe, including posterior capsule can also be involved. Iris trauma can be there. So we, as I said, we have different scenarios to face. So we have to plan how, when, and along with what the surgery for cataract is managed. So what are the issues we see? Cataract management, when do we do? Whether we do it at the primary repair when there is concurrent globe injury like a corneal tear. So if not, then timing between the trauma and the cataract surgery. When they present to you, at what stage do you manage the cataract surgery? And if you manage the cataract surgery, do you plan an implantation of the IOL primarily or secondarily? And if IOL implantation, where do you place it? And if there are additional issues, when do you plan that? And of course, every point you need to take the patient into your this thing, and you have to counsel. And if it's a medico-legal issue, that also has to be parallelly taken into account. So these are a few different issues, different situations, like 2-day-old injury, 1-week-old injury, 8-month child, bicycle injury. So all sorts of presentations. On the right side, you see a repaired corneal tear, and there is a cataract. So issue 1, like I said, cataract management during the primary repair. Do you ever have to do that? So usually no. Why not? Obviously, when there is an open globe, you want to make the globe intact first. And emergency state, you may not be in a position to do a cataract surgery. You may not be having a good instrumentation, anesthesia, all that issues. So emergency state, you try to manage only the globe. Availability of expertise, etc. is always a problem, and risk of inflammation and infection is always a problem. So cataract management during primary repair only if there is a breached anterior capsule with loose cortex in the anterior chamber, and just in case you want to really avoid multiple surgeries, if, that is the only few indications, and you can do an early rehab. So a very small peripheral corneal tear along with a ruptured capsule, maybe in that situation you can remove the cataract along with the corneal repair. And you can do an immediate posterior segment assessment if you know, if you remove the cataract. So cataract surgery during primary repair is best avoided, done only if there is a large breach in the anterior capsule. So if you implant IOL during primary repair, ideally never, but very few situations. See here you see there is a very peripheral injury 2 days prior, and here there is a very small inferior corneal injury, but centrally cornea is intact, but capsule is fully ruptured. So only wound repair is done in the first situation, obviously, but second situation, if it is an older patient and if other situations so that you are able to get a good DBR, maybe a primary IOL implantation can be considered, but usually you don't consider. IOL implantation with primary repair, like I said, is best avoided. There's obvious reasons of infection and biometry issues. So if cataract is not managed during the primary repair, then when do you manage? So timing between trauma and cataract surgery in a child is very, very important. So when we do it, next day, next week, next month, how do you decide what are the factors? So age is the first criteria. So as younger the child, you want a visual rehabilitation as soon as possible with a dense opacity in the lens. And if there is an inflamed eye with loose cortex and all that, inflammation and IOP issues is a factor which tells us what time, when to decide and do surgery. So this was a 2-day prior repair done, but you can see it's an inflamed eye. So we went ahead and we are not thinking about IOL or anything, but to control the inflammation and let the eye heal, we do a lensectomy and remove the cortex. So these are different issues. So timing of cataract surgery and IOL implantation. So you do a cataract surgery, but whether to implant IOL or not, again as a primary. So corneal injury determines when we implant the IOL, whether during the cataract surgery or after the cataract surgery as a secondary procedure. So if there is a sutured cornea, you have to wait till suture removal for at least 6 weeks and then get a good DBR, ideally 2 weeks to heal after the suture removal, and then plan your IOL implantation. So what factors decides? Like I said, PC status. If PC integrity is not good, then either implantation in the sulcus, or you can leave the child aphakic, let the sulcus rim form nicely and plan a secondary IOL. Corneal sutures are the main factor. If it is sutures are present, then you have to wait for the suture removal to get a DBR, so you have to probably do a secondary IOL. So in the bag implantation versus in the sulcus or AC IOL, SF IOL, these are options when again the capsule integrity is the main issue. So despite having a central posterior block kind of a thing following a cataract surgery, if you are able to get a nice central clear PC opening, then you can implant IOL in the bag in the situation, even if it is trauma. But here there is a PC block, but there is an anterior capsular block also, so we are not having a very good bag. So here the IOL is implanted in the sulcus. So this is like a more or less a fused capsule, cortex, everything is fused. There is even a vascular membrane there, which you have to cauterize if you anticipate bleeding, and then cut, form a rim and insert the IOL in the sulcus. So these are the few situations where IOL is in the bag or in the sulcus. So non-cataractous role, what I mean is, if cataract is associated along injuries associated with the iris issues, then see, in the first situation there is a dialysis, in the second situation there is a paracentral corneal opacity. So you need to manage that as well. So there are procedures like small procedures, but important procedures like optical iridectomy, iridodialysis repair, glaucoma surgery sometimes, and vitrectomy, all that can be indicated to be done parallel or along with a cataract surgery. So this child so you have a severe blunt injury associated with a small peripheral penetrating injury. So there is no pupil. The pupil iris is fully stretched. So a pupil had to be formed literally with a cutter, and then you find an intumescent total cataract. So you are actually doing a pupilloplasty along with the lensectomy. In the second situation, you see a corneal opacity almost touching the center, but there is a good peripheral clear cornea, so you can utilize that area. As you do the cataract surgery, you can do an iridectomy to enlarge the pupillary opening to get a better clear visual axis. And here we see iridodialysis. So many times we see situations where cataract is associated with the iridodialysis. So you have to decide if it's a very small, you may decide to observe it. So if you have to do, then when do you do it? On table, you have to do it first. You do the cataract surgery, which is a more delicate surgery. Later, so once you are very sure about the cataract surgery with a good IOL implantation, then it's better to do the iridodialysis repair, but you can do it in either order. So long-term managing trauma in children, continuous challenge, refractive changes keep happening. Amblyopia has to be managed every point, and glaucoma has to be looked for and addressed whenever you notice it, and retinal complications has to be addressed. And strabismus, of course, any unilateral issues can be associated with strabismus, so that also has to be addressed. So the take home is, you manage the cataract, but best avoided at the time of primary repair. Ideal timing is 1 week to 1 month in adults as well as children. So amblyogenic age, it is crucial to clear visual axis, but not necessarily to implant IOL as soon as you think you have to do. The DBR issues are more important than giving a IOL implantation. Primary IOL implantation has proven to give best visual outcome at all cases. Concurrent issues, whenever present, has to be looked for and managed as you manage the cataract. And long-term issues like glaucoma and retinal complications should always be looked into, and sympathetic ophthalmia as well. Thank you.
Thank you, Dr. Kavita. One thing regarding, especially in open globe injuries, if you're doing a primary thing, do you use a intravitreal antibiotic?
Not only if there is any not much posterior involvement, mode of injury, like if it's a clean injury, we don't.
Any question? Yeah, I've been giving.
No, we are not giving. Not.
No, I've been giving in all. No.
I think in
All
Shankar
cases.
Nethralaya we are not giving.
Actually, Desha group has a very large study regarding intracameral amoxifloxacin. I think yes, you can put.
In children, sir?
No, all the cases.
Almost similar result that is Orvind published that paper we have published also that our chances of endophthalmia is reduced by yeah, because It is our habit. Probably we'll give all, especially in traumatic cases, we give routinely.
Trauma, I agree.
Yeah, the Dr. Vaishali also there. Uh,
So like you, every single case.
every single case. No one want to take any chances.
No, I don't require this. So let's come to the last topic for this session, and that is pediatric subluxation. Before I start, I will just give the options that are available in pediatric lens subluxation, and at the end of the presentation we can take experiences of everyone as to what works best for them. So a large section of this group are non-traumatic and progressive, and which leads to a very high myopia and high astigmatism, and visual acuity starts dropping once the lens margin approaches the pupillary area. So the question is whether to operate or not operate. That is gone now, I think, with we have more evidence that once these children are operated, they get a good visual outcome. And what are the surgical options? So there are various options available with us. One for bag fixation, which are either Ahmed segment, Sioni ring, scleral fixated IOL, and glued IOL. So I'll go through all the options, and this is a case series what I have prepared for last almost 15 years. So all the various options have been tried, and this is the first case in which you can see that subluxation is roughly around 180 degree, and the biggest challenge in these cases is the capsular axis, because if you are not able to achieve the anterior capsular axis, then the case is gone, and then you have to shift your plan, change your plan. And one good thing about these children are generally they are beyond 7-8 years old, so posterior capsular axis can be deferred in the primary stage, and a YAG can be attempted later on. So here you can, as you can see, a small rhexis has been done, and then the capsular tension ring has been implanted first, after which the cortical aspiration has been done. A single piece lens is preferable in these cases because it's very easy to implant. And once that was done, what we see after removing the capsular hooks, that the anterior capsular axis margin is beyond the pupillary area. This is so small. So a small nick is made in that, and it was done again to get a decent size anterior capsular axis. And very important to clear the vitreous from the subluxated area, because again that may any vitreous strand left there may lead to traction and future retinal detachment. So after this, what you see is the Ahmed segment, and the difference between Sioni ring and Ahmed segment is that Ahmed segment is quite stout. Sioni ring is finer, especially the loop part of it. So this is pushed into the bag, and using a railroad technique. This earlier cases I did with 10-oproline, but now the evidence is there that 9-oproline will work better, and it will not cut through the tissue, and future subluxation of the IOL bag complex chances are much less. So, and what you see here at the end of the surgery is quite decently well centered IOL. Second option is the Sioni ring. So I ended up with a severe complication in one of my Ahmed segment. So next I decided to try Sioni ring. So here again the rhexis, and here you see the subluxation is larger than the first case. And critics of these procedure have a point that you are fixing the lens on one side. So since it is a progressive disease, it may progress to the other side also. So subsequent slides I will show you the solution to that also. So here, after the initial capsular axis, the Sioni ring is pushed before cortical aspiration, and it went into the bag very comfortably, and I was thrilled that yes, this is a better procedure compared to Ahmed segment. And the capsular hooks were removed, the ring is then the railroad technique, the sutures are pulled out. And it is a double needle tenoproline, so you need not cut in between. And after that, cortical aspiration is done. One important thing is that when you are with the devices in, the cortical aspiration becomes difficult because of the fibers getting entangled in the devices. The Sioni ring is rotated towards the subluxated side. It is anchored. And the lens is placed in the bag. So far, so good. And I skipped the complication of the Ahmed segment, but what you see next is that this is another surgical option, which is CTR is placed, and the CTR itself is fixed to the scleral. The bag is fixed using the CTR. And this was accidental, it was not by design, because first eye of the same patient did very well with CTR and fixation was not required. So I was not prepared with Ahmed segment or Sioni ring for the second eye, and after the cortical aspiration, the CTR was implanted. And the 3-piece lens is placed in the bag. Slowly I switched from single piece to 3-piece, and now most of my cases, even in subluxated, I tend to use 3-piece. Posterior capsular axis is done, and once you remove the capsular hooks, what you see is a very decentered IOL. So I was left with no option, just with a 10O Proline. I went through and through the capsular bag and anchored it to the sclera, and the results were very good. But this is the only case I have done till now, and I have not tried in another. The important question mark here is whether the bag will rupture during the procedure or not. In this case, it didn't rupture, but in other cases, it may rupture. Now, one difficult situation before this may be probably the second or third last case. So in this case, by this time I had become very confident about Sioni ring. So what happened in this case, the capsular axis is done and pulled to the center, and the difference between this and the first case of Sioni ring is that here I decided to do a cortical aspiration first and then implant the Sioni ring. In the first case, I had implanted the Sioni ring first and then done the cortical aspiration. But once I went through the Sioni implantation, it just moved out of the bag because the rhexis opening was small. And now you have a situation in which the whole ring is in the anterior chamber and outside the bag. So kept maneuvering it to push it in the bag, it would not go. And then finally I decided to give one good posterior push and in a anti-clockwise direction, and I was lucky then, and the ring went in the bag, and because I had planned that if it doesn't go this time, then I will explant and remove the bag itself. So it did go into the bag then, and after that the procedure was same. Another surgical option is just do a plain lensectomy. If the subluxation is gross, just do a lensectomy and leave the child aphakic for a future SF-IOL implantation. And this is especially if it is a younger child, because scleral fixation is generally preferred after maybe 7-8 years of age. So initial nick is made in the anterior capsule, and the controversy here is that same thing could be done with a pars plana route as well. So as an anterior segment surgeon, we are more comfortable with limbal route, and if you can remove the whole bag by tilting the eyeball, it is good enough. And coming to the next thing, what if if it is a progressive disease and we are fixed on the one side itself, and in future the other side gives way, The solution is very simple. You already have the devices in the bag. You have to just make a scleral pocket, and through the bag you have at the haptic optic junction. Same thing can be fixed from the other side itself. It takes hardly maybe 10 minutes, and that is the solution for the progressive nature of the disease. As you can see here, and one of the mistake was that the bending of the needle was not proper, so maneuverability had to be bit more, but luckily the bag didn't subluxate further. We had to rotate the needle and bring it out. Same thing is done for the other end of the needle. And at the end of it, you have a well-centered IOL. And the next option, which is again is do a lensectomy and a scleral fixated IOL, or a glued IOL. So these are the surgical options, and I think as the video is running, we can take some comments from Dr. Arup. What is your preferred choice in such cases in pediatric?
Lensectomy, and wait for at least 3-4 months, even more, then go for scleral fixation.
Yes.
This is microspherophakia, especially never, even you able to fix the bag with the sclera, with the long-term result is not good.
Sir, we have Dr. Basavada with her. It's over, sir. It's over. Okay. Then I think we'll conclude here and hand over the session to the next speakers. Thank you.
I would prefer a pars plana approach, and you can have a retractor in the pars plana and irrigation in the chamber if you want. But nowadays I have a retinal colleague always with me, so he does 3-port proper vitrectomy, lensectomy, vitrectomy. And then I used to do many things. I used to do the double Sioni ring and not do the lensectomy. Then I moved to scleral Gore-Tex fixation. But these days, for last year, I'm doing Yamani. And I love Yamani technique. And there are learning curve for any other things, but that's a technique which is very good. It's very stable. But it's a matter of your personal experience and expertise. It doesn't matter. All work good. If you want to do a sutured IOL for whatever reason, use either 5 or 6-0 Prolene or Gore-Tex. 9 or Prolene also disintegrate. 10-0 is out of question. Never use 10 or Prolene. 9-0 I have used it. We published in American Journal. But I tell you now, even 9-0 also degrades. I think it will 5-0 and 6 also will degrade one day, but maybe we will not see ourselves. So, that sort of thing. Thank you.
What is very difficult
video something or it's a PPT, right? Keynote. Okay, you are giving the keynote. No, keynote present Apple ka Mac ka presentation. अच्छा. Okay.